Thank you all very much for having me here today. I'm Robert Kerr. As they introduced me, I'm the former Secretary of Health and Human Services and left that job after about 25 years or so service in Health and Human Services, and did what all good bureaucrats do, as I said to somebody this morning, and formed a consulting firm. And I'm having a deja vu moment. Actually, one of the last speeches I gave as Secretary was in this hotel. And I think in this room, though all these rooms do very much look alike to me. And I thought it was going pretty well, actually. And I was finishing up, and a woman on the front row down here, the chairs were in rows, and she said, "Oh, please don't stop talking. We just love listening to you." And I said, "Really? I'll see if I can think of something more intelligent to say and engage you." I'm thinking maybe I should run for higher office. This is going so great. And she said, "No, we really don't give a rip what you're saying. We just like to hear your accent." That's a true story. So maybe today it'll be a little better that you'll like what I say. And Deb, I'm going to save you a little bit here. I'm going to talk at a higher level, not necessarily an intellectual level, higher level from 30,000 feet, things we ought to think about and save you some time, actually. If you'll indulge me, I'm going to cover 4 or 5 slides about managed care in general. And I'm going to talk about some experiences in South Carolina, and then I'm going to tell you some things that I personally think, which I'm allowed to do since I'm not an elected official or I'm not appointed by the governor anymore, so I can get away with all kind of things. Managed care. When we talk about managed care, what are we talking about? So I created this slide. This is out of the Code of Federal Regulations. I love the Code of Federal Regulations. I'm a CPA by training. I don't practice anymore, but I keep that license up because I said again earlier that it was so hard to get. And so I guess that's why I gravitated to Medicaid, because the code structure in Medicaid and Medicare combined dwarfs the tax code. And guys like me, we love tax code. We love to read regulations, so I get off on this stuff. So I look up in managed care. This is what you'll find in a graphic form. Unfortunately, you'll never see the graph from the feds. You'll see words. And it says, here's how we define managed care. And it's really by levels of risk or capitation. There are 5 different plans that the code describes there. To the far left means no risk. That's what you'll hear when we say fee-for-service. Claims paid by a Medicaid agency. Not many controls. The agency's totally in charge. We don't use third-party contractors. You move toward the right end of the scale, and you'll see primary care case management plans. That's still a fee-for-service plan, but we will pay primary care physicians or an entity to assist primary care physicians a case management fee. And maybe the case management fee is at risk, so virtually not much risk. Move toward the center of the scale, you see 2 kind of plans called prepaid inpatient. Health plan is exactly what it sounds. It is capitation for inpatient cost only. And then there's prepaid ambulatory plan, which only, as the government can do, is capitation for everything but inpatient plans. And it can be really no more than 3 other services. And then finally, to the far right, there's what we call managed care organizations. And what I'm going to talk most about today is full risk, full comprehensive managed care. So what does that mean? That means it must cover, an MCO must cover inpatient care and 3 or more general services which are listed in the CFR. Can't cover 2, can't cover, have to cover inpatient. That's full capitated risk. When you hear Medicaid directors talk about flexibility, this is what we're talking about. We have to fit in one of these categories, or we have to go get, as you heard yesterday, the 1115 waiver, or 1932 A, B, C, D, E, F waiver, on and on. Capitation, as you probably all know in this room, but essentially capitation means I'm going to pay a third party to deliver services on our behalf of a recipient, and I'm going to pay that individual, that third party, regardless of whether the recipient receives services. So I may pay you $100 a day to pay for a Medicaid recipient, and you agree to cover all the services, whatever we agree to in that contract, for that Medicaid recipient. And the theory is it saves a good bit of money. We'll talk about that in a minute. If you look on the scale of managed care plans from primary care case management to managed care organization, around the country, roughly half or more individuals are enrolled in managed care, full risk, comprehensive care organizations. Now, as I said a minute ago, not all services have to be in an MCO. This is just a chart came out of the Kaiser Family Foundation, which is Wealth and Information. that shows out of those, and it says 36 states because this is 2011. There are actually 38 states that do full risk managed care. Here are a couple of services that are carved out. Dental almost always is carved out of managed care. Behavioral health, as you heard Darren talk about, substance abuse, a form of behavioral health, non-emergency transportation, which is a whole 2-3 hour long conversation we could have in Medicaid on its own right, prescription drugs, another detox, vision care, and other. And then that other that you don't see, almost no state, except for, with the kudos to you guys, actually does managed care and long-term care. Very, very seldom do you see it. Now, in South Carolina, I retired actually in 2007, which seems like a lifetime ago. When I was in director, we actually had very little MCO penetration, about 10%. We didn't like it. We paid claims well. We're a full service state. Within actually 2010, this is 2011 chart, you can see things flipped. We had 73% of our enrollees in managed care, leaving 27% in fee-for-service. If you look to the column to the right, our spending, however, was still predominantly managed care, fee-for-service, 72%, and we had 28% going to MCOs. So 73% of our individuals were in managed care, 28% of our spending going to those companies. Interestingly enough, this is the national numbers. Wow, almost the exact same. All right. So around the nation, 72% of people enrolled in managed care, about a quarter of Medicaid costs go to those managed care companies. I just broke this down a little further because I showed you that slide with all these different kind of managed care types of options up there. The red being MCO, full comprehensive risk managed care, which is typically what we think of. The yellow being all those others, PCCM, and all the acronyms that only the government can come up with, prepaid ambulatory health plan, prepaid inpatient plan, all those are in yellow. What's the interesting point about that? Well, 24% of people enrolled in those, only 3% of spending goes to those alternative managed care plans. I find that fascinating. This is a little bit of a crowded chart, but this is a good one for us. This comes out of the report to Congress from MACPAC. It shows on the far left the total spending. I've tried to break it down by eligibility and service. The blue section is acute care. 41% of all spending goes, essentially is in acute care. 24%, as we covered a minute ago, goes to MCOs. But look at that kind of brownish section. 32% is long-term care. The top is purple. I didn't put an amount on their percentage because that's Medicare premiums. If y'all know, Medicaid pays premiums to Medicare. Another 3-hour conversation we could have that was actually has some demonstrations in the Affordable Care Act, which we hope will help solve some of those problems. If you move to the right, you can see children, 53% acute care, 44% comprehensive long-term care. Same thing in adults, very close, meaning a lot of children, a lot of healthy adults in managed care, right? If you look over at the disabled, it drops down, and then in the aged, 60%, 66% of coverage is in long-term care. Very small percents in comprehensive managed care, 9%, 15%, very small. Now I'm leading into some of my favorite charts as a Medicaid director. This came out of, you'll see this chart everywhere. Kaiser's got it. This is actually on the MACPAC chart. And kind of breaks down into 4 general categories of enrollment. Now we all know there are many, many categories of enrollment Medicaid. I think there are 49 in total that you can choose from in the country. South Carolina uses 45. But if you try to break it down in general sections, if you look at the top, the purple section, that's children. 48% of people in Medicaid are children. 19% of spending goes for children. 28% are adults, 15%, that's generally healthy adults, not aged, not disabled. 15% of spending goes to that group. 15% of the population is disabled, and how much spending goes to that group? 43%. 10% is aged, over 65, and 23% of our spending. This is why I said I was going to talk generally, Deb. You can't run a Medicaid program, you can't run any health care plan, you cannot be successful in any of this material until you start to grasp these concepts. When a Medicaid director, and Darren, I'd love to see if you say the same thing, but When the Medicaid Director looks at his program or her program, she's essentially going to see this pie chart. It's going to be broken down in 4 categories. It's going to see acute care, and about 1/3 of that expense level is going to be in acute care. General inpatient hospital, outpatient hospital, primary care. Right? The other 1/3 is going to be in long-term care, predominantly nursing home institutionalization type care. And there's one other 1/3 that's going to be in disabled. And that last sliver, which is really a portion kind of acute care, it's a slide over in institutionalization, is mental health, behavioral health. And it covers about 10 to 13% of your cost. And so you have to think, well, all right, that's what my program looks like. What am I trying to accomplish? I'm going to bring that home in a second. I'm going to flip to talk about capitation, because what we did in South Carolina very rapidly was ramp up to managed care, almost honestly too rapidly. And so I wanted to give, because Deb asked me, what the results of capitation was. And this is an indictment on MCOs and managed care by any stretch. I'm going to talk about that. There's a role for that, and we're actually heavily moving into that and Medicaid, and probably can't retract. This are lessons learned as South Carolina made some mistakes as it went through it. And it's interesting, I showed you where children and adults are essentially covered in Medicaid managed care. But our spending is low there. What did we do? We allocated the lower risk, more predictable populations. We knew how much children cost. Give me all the children you can in Medicaid, please. They are inexpensive. I used to say cheap, but my staff would always poke me when I said it. Please do not call children cheap. They're inexpensive. So are general adults who have chronic conditions, who are not disabled, who are not aged. So yeah, I can predict fairly correctly what the cost of an individual coming on Medicaid is, so therefore it lends itself to capitation. Sounds like a great idea, right? Our cost was not in those groups. So we paid capitation rates on individuals that need less management. We found there was wide variation among plans' ability to coordinate care. In all honesty, and this is another thing I'd say, and I get poked around, the managed care entities and organizations in Medicaid are fairly immature entities. We did not have Medicaid managed care, I don't think, until maybe mid-1990s. Yeah, I think Tennessee leaped off the cliff first.
Arizona was up there.
So what?
Arizona just.
Yeah, Arizona never had anything with a managed care plan. Other than those 2 states, there wasn't a lot of movement in it. So those companies are learning just like we are. And what we found is many of them didn't have the tool set to do care coordination any better than we did. Interesting, in South Carolina, what we discovered, and it's actually illegal to do this on prepaid ambulatory and inpatient plans, but in MCOs, they were passing through our fee-for-service rate structure, mainly because we told them to, which was idiotic on our part. So they would go negotiate rates, negotiate networks, and use the Medicaid fee-for-service rate schedule as their basis. So what good was that for the program? Actually created a problem, because the next step we had too many plans, which resulted in higher rates, exactly opposite of what you think. And healthcare is so many oftentimes that if you try to apply economic theory to healthcare, you get baffled quite frequently. You would think more plans, more competition, rates go down. Wrong. We at one point had 9 plans in the state of South Carolina, which we have a fairly robust Medicaid population of about 1 million people, but it really can't support 9 plans. And in order to grab market share, we forced the plans to do what? Compete for rates. They raised primary care rates, and in some cases even hospital rates, which brought pressure back on us, which also goes to one of the points. In order to ramp managed care up quickly, the state reduced its network adequacy requirements, which helped the plans move in, meaning they were looser on their network requirements. In other words, how many hospitals, how many specialists do you have to have a valid network? The plans proliferated. We had too many plans. They're negotiating too high rates. Our budget went through the roof. Not the plan's fault by any stretch of imagination. That was our fault. We have to implement by federal rule, and this is a pet peeve of mine, but actuarially sound rates, and guarantee is not really a fair word. Actuarially sound rates guarantee increases. What the heck is an actuarially sound rate? Now, I'm a CPA, if I were what I've learned in Medicaid,
You should have been actuary.
doggone, I cannot afford to hire an actuary in the state government. I should have gone to be an actuary. I've also learned that actuarial work is an art, it is not a science. Right? Actuarially sounds mean whatever I can get an actuary to sign off on. Literally, that's what it means. The law used to read it had to be actuarial equivalent. So if I had a fee-for-service population, I knew what I spent on that population. I knew what I should be spending on my Medicaid capitation, correct? What happens when I move heavily from fee-for-service over to capitation? I no longer have a basis for which to gauge actuarial equivalency, correct? So the federal government, in its wisdom, understood, ooh, we can't have that rule anymore, so they changed it to actuarial soundness. What's the problem with that? Is I get into a huge argument now when rates need to be leveled or reduced because I'm in a budgetary problem in state government and I'm bound by, actuarial soundness, which means whatever it costs the capitated plan to deliver the service. No problem. Let me skip some of the better. The state in South Carolina, and I think Darren said this well, had difficulty transitioning to the administrative infrastructure needed to contract and regulate plans. And this is one of the things we want to talk about, because you can see the other things. We had too many plans, we overburdened providers, we rolled out mandatory enrollment too quickly. We did it on and I can talk about this because I wasn't here when we did this. I did it after I left. We rolled out by county basis. We didn't even go to regions, which was really not smart. The problem was, and I fully believe this, there's some good attributes we're going to talk in a minute about managed care, MCOs, and you're probably going to drive Medicaid fully to that. You really, honestly, are going to have no choice. But what the state did was give up the things it does very well and tried to keep the things it does not do well. And what do I mean? What happens in the private sector and what happens for the plans that came on, they are used to going to providers and saying, I'm going to form a network. I'm going to be a Medicaid managed care company. And in South Carolina, at one time, as I said, we had 9 of these guys running around going, gee, I want you to be in my physician network, and I want you to be in it. I really don't want you because you're expensive. I want you to hospitals, and I'm going to negotiate this great rate. If Medicaid, and South Carolina actually paid some pretty good rates, another 3-hour speech I'd give on why we like high rates in South Carolina is because we have 70% of the federal government paying the bill. But what's the problem in most states? If Medicaid rates are low, how much negotiation can a company really achieve out in the marketplace? You really can't. And so it seems a little odd to me to build a model on these two things. Let's form a network and let's negotiate low rates when rates are already pretty low. So what does the Medicaid agency do well? I already had a network. Now granted, it's hard to get providers to participate, but I had a great network in South Carolina. We had a lot of people participating in Medicaid. I didn't need to create another one. In fact, when I went to 9 plans, what I do, I diluted that network. I already had pretty good rate structure. I could control rate structure. I always said the Medicaid Director is probably way too powerful, one of the most powerful positions in the state. They control a massive budget. And if you're in a cabinet state, you don't have anybody looking over your shoulder when you set rates. We have a public service. I always find this odd. My goal in life is to be head of utility. I failed because it's a public monopoly, and I know, I'll get a lot of things thrown at me that, particularly from my friends back home. But that's my goal. And if you're in a public utility, they have a public service commission in South Carolina. Every state's got it to monitor rates. Who monitors you when you set rates?
Some of the people in this room.
Correct. And that's it. That's it. And I don't necessarily have to have your permission. Now, I go to that well one time, I learn real quick. But I have immense control. But also a whole lot of pressure to make sure I keep those rates. When I pass them through to the third party, I lose some of that control. So what I do well, I have rates, I have networks. What did I do really poorly? coordinated care, data analysis. We are horrible at it. And I'll be honest, I haven't found a state, maybe the exception of you guys, that is very good at it. We did not do it well. And that's what managed care is about, and that's why we should have engaged the companies who were better at that than us, much better at that than us, and used our network and used our rate structures appropriately. I'm not sure it's a great idea to pass total risk over to the company. Because the truth be known, everybody in this room, and I think the managed care companies would agree with me, they own a fair amount of risk, and yes, I understand the shareholders are going to be looking at it, and understand cash flow creates a lot of problems, but at the end of the day, who owns that risk? The state government. It will not give that risk up no matter how hard it tries. It will not give it up. It can't give it up because the managed care company is going to come right back to who and say, we can't afford to operate in the state because it costs X and I'm being paid Y, and that's to you. So we built a structure that sounds great. And I'll tell you why it sounds great. So why managed care? We love budget certainty. I can go to you and say, it's only going to cost X to do Medicaid next year. Even if it's more, I can tell you exactly what it is. And supposedly that's good. The good parts of managed care is a lot of plan flexibility. I'll give you an example. Long-term care. Most states cannot do assisted living long-term care. They have waivers to do it. And the feds are actually cracking down on the few waivers that are out there. I can't go put a person in assisted living. I can ram them into a nursing home, or I can give them what we're so proud of. We call it CLTC, Community Long-Term Care Waiver, where we can put them back in their home and put supports around them, ramps, air conditioning, which is good. We can do those things. But the honest truth is, so few people have the infrastructure at home to truly care for themselves. And they met long-term care. They met nursing home level of care, but I'm thinking I'm better off putting them home. All honesty, they probably needed something in between, but the Medicaid Director has no capacity to do that. The managed care plan can. They can do that. So there is an advantage of flexibility. Reduces administrative load to a sense, if you're smart, and this is the ultimate thing. And the director that's there now, Attorney Katz's really good. He's a smart guy, and he and I get along very well, and he's remedying a lot of these problems. You cannot live in both worlds. Tennessee was smart. They either did it or they didn't. You cannot live as a payer, as a state, as a claims benefit payer, a fee-for-service entity, or a managed care regulator. It requires two different skill sets. It requires two different administrations. For example, I've got to have a Medicaid Management Information System, an MMS claim system that costs a lot of money. No matter how many claims, when I have 100,000 people or a million, I've got to have the same system, the same very expensive system. And I'm going to maintain that while I'm going to go to managed care. My administrative costs double, and very few states make that transition. They want one foot in both worlds, and you cannot survive that. The last thing why I think managed care is going to take over in more capitated form, which I think, again, is a good thing. And this is a nonpartisan discussion. Okay. If the Affordable Care Act stays in place, which I have all confidence that I'm sure it will. Now, it may look a little different, but it stays in place. Ultimately, even great states like South Carolina, who chose not to expand Medicaid, will ultimately do so. We didn't do it in 1965. We said we never participated in it, and in 5 years we do, and in 10 years we're one of the largest drawers of disproportionate share funds in the nation. We will do it. Every state will ultimately do it. It is much better to transition for those individuals in an environment that they will be used to. For example, exchanges are run through capitation type plans. In order to have a seamless transition between exchanges and a seamless transition in Medicaid, I would argue that managed care plans set you up for that much better than if you're trying to run a fee-for-service. Now, there may be some exceptions. If you're a small state, Connecticut may very well can run a state on their own. South Carolina with 1 million beneficiaries cannot. And I want to close with a couple quick things. I'll give you my most favorite slide that just kind of covers the same thing that I've been talking about. If I leave you with anything, if you do hear anything I say other than my accent, which I really don't think I have an accent. That woman insulted me so much. I love this slide, and I'm sure you've probably seen it. But it takes enrollees and spending. The blue bars are enrollees, the red bars are spending. It's concentration Medicaid spending, and I promise you, I do not care if it's Medicaid, Medicare, TRICARE, Blue Cross Blue Shield, private state employees, your personal insurance. It is the same dynamic in every plan. And I'll pick one out for you. Well, I'll pick a couple. 5% of the Medicaid population cost 54% of our costs, which says the same things as the earlier slides I was giving to you. 5% costs 54%. 25% cost us 85%. In other words, the 80-20 rule is alive and well. The fallacy of what we did in managed care, if you look at the far right, where 95% of our population cost us only half our cost, we took the bulk of our population who did not cost us much and moved it to the entities to manage care. Ladies and gentlemen, that population didn't really need a lot of managed care. The populations that needed the managed care did not get moved in. And that's the state's fault. Now, I know companies have trouble figuring out how to do behavioral health managed care. I know companies cringe at thinking how to do long-term care, but they can do it. They're better equipped at it. We do not do it well. Until you decide to move the very populations that are costing you money into true managed care of multiple forms, you will not save money. And if I have any argument with the Affordable Care Act, and there's some really great things in there, and I personally think we will expand and should expand, we do not address our cost problems. Until we focus on that 25% of the population, we will not solve our problems. I don't care how you dress it up. I don't care whether you go full managed care, fee for service, they're both. You can operate both. But until you solve that problem, you're not going to do it. Last thing, and this is a little outside of managed care, because Deb asked me to say, what would you do if it was just you running the world, which thank goodness it's not. You know, I have to sit there. We were at a conversation around the table this morning, and it rings true, and it's particularly true in rural states. And Darren, you said that, I did not realize that. Johnson City, Tennessee, a beautiful city. It's literally closer to Canada than Memphis. That is a great analogy, because here's what I'm about to say. I think at the table this morning, southern Nevada. Most of those people go to maybe California for their care. Northeast South Carolina will go to North Carolina. Half our people in Augusta go to Georgia. We have a lot of people in the border states who will come to Medical University of South Carolina because it's a great institution. It strikes me as a little odd in this day and time, and I come from the hotbed of states' rights. So this is heresy about what I'm about to say, and I'll catch it later. Why in the world do we think it is a better operation to have one class of care for Medicaid recipients than we are willing to have for ourselves? I do not understand. And what do I mean? I'm not bound within the borders of South Carolina where I get my care. If I live in southern Nevada and I need to go to the closest, best provider in California, I typically can get there. But if you're a Medicaid recipient, unless that provider's within 25 miles of the border, you can't go there. Unless you come to see me and I approve it, of which I really can't do that except for children. And in some odd circumstances, which is one of the toughest decisions a Medicaid director will have to ever make, I can't do that. And so I got to sit here and wonder, the states put up a fair amount of money in Medicaid. Why aren't we federalizing Medicaid? Why aren't we thinking about this concept? And I get how expensive the federal government is. I get we don't want to create more federal programs, but you cannot tell me that I cannot create a program where the state buys into it, reverse capitation, reverse the discussion of block grants, frankly, and say, you run it like Medicare. I'll pay in on a per capita basis. And you take care of it so that patients have seamless care. Now, federal government, I'm going to put my money up as long as you take the risk to make sure that you don't blow the doors off a cost. Because if you do, you have to eat it, not me as a state. Why wouldn't you do that? Why wouldn't you give seamless care like I get for everybody over 65 in South Carolina in the Medicare program? Now that I've thrown that out there, I get to walk away and sit back down. Because I don't have to go back to the state legislature and say that, because I know I could never get away with it before. And I don't have to report to my governor saying, what in the heck were you doing when you sat there and talked about federalizing the Medicaid program? With that, I'll be quiet and sit down. Thank you very much for your time.